Okay, I'm sure before we go into the details of coagulation disorders, I would like to recapitulate the coagulation pathways. I'm sure you're all familiar with these two pathways, the intrinsic and the extrinsic pathway. The extrinsic pathway involves mainly the factor 7 and the tissue factor, which is released by tissue damage. And the intrinsic pathway involves factor 8, 9, 11, 12. And then there's the common pathway, which involves factor 2, 5, and 10. 2 meaning prothrombin, 1 is fibrinogen. So 1, 2, 5, 10 are common. 7 is the extrinsic pathway, and 8, 9, 11, 12 involves the intrinsic pathway. You kind of need to remember these for future reference. Okay, so now we'll move on to the next thing. Okay, so just to remind you that the test for the extrinsic pathway, whether the extrinsic pathway of coagulation is intact, we look at the prothrombin time. Okay, and to see if the intrinsic pathway is okay, we'll look at the activated partial thromboplastin 39. The prothrombin time is about 12 seconds. So you need to know the normal levels of these. Let's discuss a few common questions asked from prothrombin time and APTT. As I told you, prothrombin time is a measure of the function of the extrinsic pathway. The factors involved in the extrinsic pathway are 2, 5, 7, and 10, mainly 7. So these are vitamin K dependent clotting factors. Okay. So deficiency of any of these factors or deficiency of vitamin K, for example, in liver disease, would increase the prothrombin time. Warfarin is an anticoagulant, as you know. It acts through the extrinsic pathway. So you have prothrombin time to measure following warfarin therapy. As I said, liver function. These are the 3 important uses of the prothrombin time. So this is pretty important. Liver disease, vitamin K deficiency, and follow-up after using warfarin. So these are the important uses of prothrombin time. Okay. We know about heparin. Heparin does not affect prothrombin time because it acts through the intrinsic pathway. So what about the activated partial thromboplastin time? Where is it used commonly? It is used commonly in 3 conditions. Basically, as I said, following heparin therapy, we monitor the APTT to diagnose coagulation disorders like hemophilia and von Willebrand's disease. As we know, these are diseases due to deficiency of factor 8, which we saw that it is involved in the intrinsic pathway. So APTT is used to monitor treatment with heparin and to diagnose diseases like hemophilia, von Willebrand disease. So this is the important use. So let us look at this table where we use a combination of prothrombin time and APTT to diagnose different conditions. Okay, so in your exam, you will have different scenarios where you will have lab tests of prothrombin time and APTT given. So you'll have to interpret your case accordingly. For example, if a patient has a prolonged prothrombin time but a normal APTT, as we saw, liver disease, warfarin therapy, decreased vitamin K, these are the conditions causing this combination of results. A normal prothrombin time, prolonged APTT. You will see that in von Willebrand disease, in hemophilia, in heparin therapy. If both are prolonged, very important, DIC. We'll be going through that a little later. Disseminated intravascular coagulation. Both PT and APTT will be prolonged. Okay, so keep this in mind as we go forward. Okay, this is another way of looking at the combination of lab results. What do we get in warfarin therapy? I'll put the question in another way. We will get a raised prothrombin time. APTT is usually not raised unless it's very severe or prolonged case. So you'll just remember a normal APTT. Platelet count will be normal and the bleeding time will be normal. In DIC, as I told you, the prothrombin time will be raised, APTT will be raised, the platelets will decrease, bleeding time will be raised. We'll study about DIC later on. What about in the coagulation disorders, hemophilia, von Willebrand disease? Both of them, the prothrombin time will be normal because they don't involve the extrinsic pathway. The APTT will be highly raised in hemophilia, just mildly raised in von Willebrand, may even be normal. Platelets will be normal. Bleeding time will be raised in von Willebrands. Okay. So we will need this table later on as we move forward. So you have cases in your exam with these combination of lab results. You'll need to interpret them as to solve your answers. Okay, now let's go through the individual conditions. Hemophilia, you're all familiar with. It's a coagulation disorder where there is deficiency of factor 8 in most cases and also factor 9 in 20% cases. So you have two types of hemophilia, hemophilia A and hemophilia B, due to factor 8 and factor 9 deficiency. Okay. So the important point, these are X-linked recessive disorders. X-linked recessive disorders. Okay. So basically, males will be sufferers and females will be carriers. You won't have, it's very unusual to have a female suffering from hemophilia. And as I told you, it's due to factor 8 and 9 deficiency, which are clotting factors involved in the intrinsic pathway, intrinsic coagulation pathway. Okay. What is the common presentation? You will usually get a scenario where a child has bled after a mild injury. They will be bleeding in the joints or the muscles, or following dental extraction, there will be profuse bleeding, or after surgery, there will be profuse bleeding. So these are the scenarios you will get in the exam, which will point towards a diagnosis of hemophilia. So what are the lab results that we will get in hemophilia? I already gone through them. I'll just summarize for you. You will get a prolonged APTT, a grossly prolonged APTT. The bleeding time and prothrombin times will be normal. And if you do, after that, if you do a factor assay, factor 8 or 9 levels will be low, which will point to the diagnosis. You treat hemophilia with factor 8 or 9 replacement. That is the definitive treatment. Okay. So look for a young patient presenting with bleeding in the joints or muscles with a prolonged APTT, which will point to diagnosis of hemophilia. Von Willebrand disease is another coagulation defect. This is due to von Willebrand factor deficiency. Now, where do we need von Willebrand factor for? Let me show you the normal function of von Willebrand factor. This is needed for platelet adhesion to vessels after an injury for hemostasis. So they are needed for platelet adhesion. They help the platelets to bind to the injured endothelium. They also carry clotting factor 8. So von Willebrand factor has important functions. So if this factor is deficient, there will be prolonged bleeding. This is the most common inherited bleeding disorder. It's autosomal dominant. So males and females are equally affected. So what is the important function of von Willebrand factor? This is asked sometimes. It binds to collagen, subendothelial collagen, and to GP1B receptors on the platelets, helping in platelet adhesion. So this is an important function you need to know. This is sometimes asked in the exam. It also protects factor 8 from breaking down. So a deficiency of von Willebrand factor will prevent platelet adhesion following endothelial injury. It will also not allow deficiency of von Willebrand factor will also not allow factor 8 to function properly. So that's why you have a bleeding problem following von Willebrand factor deficiency. Okay, so this is another illustration of von Willebrand disease. Von Willebrand factor is in fact present in the endothelial cells of the blood vessel, also in the platelets. Okay, so secreted from both sides, and it binds to factor 8 and helps in coagulation. There is an important enzyme here, as you can see, Adams 13. Von Willebrand factors are large molecules. Adams 13 is an enzyme which helps keep the size of the von Willebrand factors small. Otherwise, there will be big clumps forming in the blood vessels, clotting the vessels. So presence of this enzyme is very important, and deficiency of enzyme leads to another disease called TTP. We'll be learning about it later. TTP. Okay, so keep this in mind. We'll study about this enzyme deficiency when we talk about TTP. So at the moment, we are talking about von Willebrand disease. So as we have seen, von Willebrand factor has an important role in coagulation. So either there is a total deficiency of von Willebrand factor, or there may be sufficient von Willebrand factor, but may be dysfunctional. So there are many subtypes of von Willebrand disease. We don't need to know all of them. Type 1 is the most common, where the von Willebrand factor is reduced. Okay, so we don't need to know the other types because they are rare and not important. Type 1 is the most common type of von Willebrand disease.